So our next speaker is Dr. Marlon Danilewitz, who is in his third-year research track as a psychiatry resident at UBC and a Rising Addictions Medicine Fellow at BC SSU, as well as an APA Leadership Fellow. Prior to medicine, he worked as a yoga instructor, which has had profound influence on his clinical and research interests. As a researcher, his work focuses on physician and medical trainee health, mindfulness meditation, leadership in medicine, and brain stimulation. Marlon is an active physician leader and a passionate advocate of physical wellness. In his spare time, he also enjoys traveling, open water swimming, and yoga. Join me in giving him a round of applause.
Can everyone hear me okay?
Yes.
Perfect. All right, well, thank you so much, everyone, for coming out tonight. My name is Marlon Danilewitz, and I'm a resident doctor here at UBC. It's a great privilege to be here tonight to present as part of the BrainTalks series, as well as just to present to you on the topic of burnout in medicine. So to start off the talk, I'd like to begin by posing the question of why we should all care about this topic of burnout in medicine. Not everyone in the room tonight are physicians or medical trainees, so why should we care? So by a show of hands, who here works in medicine either as a physician or as a medical trainee? All right. So for those of you who are doctors and medical trainees, this topic here is really vital to us tonight to understand how this impacts your own health and well-being. And what we'll be looking at tonight is how the nature of medicine impacts levels of burnout, depression, and other indices that are really vital to our own workforce. By a show of hands, who here in the audience work in allied health professionals? So a number of you. So it's really important, this topic to us tonight, for those of you who work in allied health, given that these are your colleagues and that their behaviors impact you. And we do know that people, or doctors I should say, that suffer from burnout have higher rates of unprofessional behavior, dishonesty, and other misconduct that can impact the workforce. I'm sure all of us here are patients, or will be, or at one time in our lives, or have those of us in our lives who are patients. And so we know that burnout in medicine is an important indice because it impacts your doctor's ability to provide adequate care. Burnout in medicine contributes to lower rates of empathy and compassion amongst those physicians, as well as it increases rates of medical errors that impact the quality of care. For us as a general society, the impact of burnout in medicine is quite profound, as we know that burnout in medicine increases rates of turnover, absenteeism, and presenteeism in the workplace, which have significant tolls on the economics in our healthcare system. But burnout in medicine is more than just numbers, it's about people. And what I'd like to, or who I'd rather like to introduce you to, is a gentleman by the name of Adam Hill. And Adam Hill's story appeared in the New England Journal of Medicine a few months ago. The highest impact journal really in medicine today. And it relates to Adam's story. And here it is. My name is Adam. I am a human being, a husband, a father, a pediatric palliative care physician, and an associate residency director. I have a history of depression and suicidal ideation, and am a recovering alcoholic. Several years ago, I found myself sitting in a state park 45 minutes from my home on a beautiful fall night under a canopy of ash trees with a plan never to come home. For several months, I'd been feeling abused, overworked, neglected, and underappreciated. I felt I had lost my identity. I had slipped into a deep depression and relied on going home at night and having a handful of drinks just to fall asleep. Yet mine is a story of recovery. I'm a survivor of the ongoing national epidemic of neglect of physicians' mental health. So the goals of our talk tonight are, one, to appreciate the prevalence of mental health outcomes in medicine, two, to understand the underlying causes of burnout in medicine, three, to appreciate the implications and the impacts of burnout, and finally, hopefully, if my talk is successful tonight, we can join together in advocating for improved conditions to help with the situation of burnout in medicine. So what's my connection to this topic tonight? So I'm a man who wears a number of different hats. As a researcher, I've been involved with physician wellness in the capacity of doing major national studies looking at rates of medical student well-being. As well as a researcher, I've looked at interventions, and most chiefly in looking at mindfulness interventions, both face-to-face and online modalities, to help curtail burnout amongst medical students. Over the years, I've also worn the hat as an advocate and leader, sitting on the boards of the Canadian Medical Federation of Students, resident doctors of BC, most recently BC Psychiatric Association, and I've also been involved in the narrative medicine community here as well. On a personal level, I'm someone who cares about my own wellness and that of my colleagues. I've invested over the year in my own wellness by enriching my life with yoga and meditation, and I think those are some of the reasons why I'm here tonight. Before I move any further, I'd like to express a tremendous amount of gratitude for all the people that have been assisting for me in the past. In particular, the research teams that I've been involved with here at UBC, as well as in Ottawa and across the country. Individuals like Brandon Masser, Rachel Holton, Erica Frank, as well as Drs. Diana Kashiki and Jacques Radwin. I've received funding for research from the Canadian Medical Foundation, never received any industry ties. And for this presentation, I'd like to really thank a good friend of mine, Monique Gottlieb. So, in the news recently, there's been a tremendous amount of attention in burnout in medicine. It's become quite a timely topic with many headlines. And recently here in British Columbia, it's drawn a significant amount of attention at the doctors of BC, drawing a lot of concern with increasing rates of turnover amongst physicians here in our workplace. So I want us to consider the 5 most pivotal impacts of burnout in medicine. And ultimately, when we look down the road, burnout and its relationship to depression and other factors has an untoward effect on raising suicidal thoughts and ultimately leading to increased rates of suicide amongst physicians, with higher rates specifically in women. In the US alone, there are 300 to 400 deaths each year by physicians. That's the equivalent of the entire class of UBC medical students in 1 year. Beyond that, we see that burnout has a profound effect on absenteeism, with increasing numbers of physicians taking time off work because of unaddressed mental health concerns. We see a rising cost in terms of the turnover, and this is quite profound, especially in Canada, where we know the provinces bear the brunt of training medical students, and the cost is in the order of hundreds of thousands of dollars. With physicians leaving the workplace, that's a tremendous burden on our healthcare system. Finally, we have healthcare coming into effect in the context of professionalism and empathy. And most concerning is its impact on patients and the capacity of medical errors. One of the understandings we know is that amongst residents, they identify that those suffering from burnout, in comparison to those without burnout, have a significantly higher rate of committing medication error, 33% in those with high rates of burnout versus 1.1% in those with low rates of burnout. Similarly, among surgeons, the realities are quite concerning. And the way I think we can conceive of that is with a standard model, what's being said to underscore errors in medicine and other workplaces with it's called the Swiss cheese model. And as you can see here, you have a number of layers that have to overlap in just the right way. So an error actually comes to fruition. Typically, there are a number of barriers that prevent this, but if just a certain right combination occurs, an untoward effect can happen in the context of a patient safety incident. Now, the metaphor, what I want us to think about in terms of physician burnout is that we move from a Swiss cheese that has very tiny holes, or very few holes, to a Swiss cheese that has quite profound gaping holes. And it's much easier for things to penetrate further, leading to an untoward consequence down the road. As Dr. Love alluded to before, burnout is an accumulation of physical and emotional exhaustion caused by long-term exposure to demanding work situation, and a cumulative result of stress. Most typically, we look at burnout having kind of 3 domains: high emotional exhaustion, which tends to bring about high rates of depersonalization or cynicism, thinking poorly about one's place in the workforce, as well as a low sense of personal accomplishment and efficacy. When we think about the generic causes of burnout as well, quite similar to what we discussed about before, a sense of lack of control, unclear job expectations, poor job fit, and extreme work conditions like increasing number of work hours. Now, the story of burnout in medicine begins at medical school. Medical students enter medical school at no increased rates of burnout or depression in comparison to their age-matched controls. However, with the start of medical school, rates of depression rise by 13.5%. And the burnout ranges in medical students is about 45 to 71%, with rates of depression on average being about 27%. So there must be something about medicine that is linked to this. That on the outset we might be inclined to think that there's something incredible about healing. But when we look more deeply at it, we can recognize that there's actually something quite profound to the nature of working with suffering on a day-to-day basis. And to understand this a little bit better, I want to turn our attention to quite a famous thinker by the name of Dr. Rita Sharon, who pioneered this area of medicine called narrative medicine. And in her book, she discusses the following. The doctor, too, undergoes deep and painful emotions in his or her care of the sick. Although the patient's suffering must remain at the heart of medicine, it is undeniable that doctors, too, suffer through the illnesses of their patients. The most moving evidence of such emotional suffering is to be found in the hundreds of memoirs of training written by medical students and physicians. Although the specifics of the suffering may change, the heart of the suffering remains the same. Shame at being powerless, guilt and rage in the face of blame, and the fear of all the dying. Beyond this inherent division in the nature of medicine, there are a number of other factors as part of the institution of medicine today that contribute to increased rates of burnout and mental health outcomes amongst medical trainees and physicians. In the professional realm, we've already discussed the elements of patient care, the burden of supervisioning learners, information overload as we see that more and more information is becoming increasingly demand, career planning. On a personal level, there's family obligations, finances, especially with increasing debt associated with being a medical student, limited time for self-care and adequate coping. And on a situational level, we know the impacts of sleep deprivation, of a heavy workload, and of an unfortunate working environment. Now, thinking about this as a process, what I want to introduce you to is probably something that many of you are familiar with, is that the idea that onto itself, stress isn't necessarily a bad thing. That we know to do well for a certain test, we need a certain amount of stimulation of stress to encourage us to study. However, with too much stress, we can't function. We can't study for that test. We become immobilized. And similarly, with overwhelming amount of stress over time, we arrive at the situation of burnout. Now, we've spoken a bit about these factors of burnout and depression in medicine, but what about in Canada? Now, over the years, I've had the opportunity to be involved with some important research here in Canada looking at rates of medical student mental health. And the importance of that is that we know there's a significant variation in mental health outcomes between studies in where they've taken place in Canada versus the United States or other countries. And in fact, there would be no significant research today in Canada in terms of medical student well-being. So we started the first Canadian medical student survey, and we had a significant sample size of one of the largest studies to date of over 4,600. Now, what separated us from other studies was that we had more robust data, both because of our large sample size, but also because of the nature of the questionnaires that we use, specifically asking individuals about their diagnoses. Whereas other studies tend to ask screening questions, getting to understanding depression, often overinflating that data. And finally, what was really helpful about our study was that we used comparison data using the same questions from the Canadian Community Health Survey, so we could compare our data to age and education match controls. So in this table over here, what I want to draw our attention to is the reality of depression and anxiety in medical students in Canada. And what we can see here, point to that, is that rates of depression and anxiety tend to increase with increasing years of study in medical school. Looking at the third and fourth year, they tend to be more profound in their impact versus the first and second year. And that corresponds to the change moving from classroom study to being in the clinical environments. More importantly, you also see here that in keeping with existing data and general populations, women in particular are more at risk for depression and anxiety amongst medical students. When we compare our data, looking in the left column versus the right column, with the post-secondary matched controls of the same age, we see that medical students, both male and female, are at a higher rate of depression as well as anxiety in comparison to controls. Moving forward, and what's quite alarming, is that these diagnoses further predispose individuals to having suicidal thoughts. And in comparison to their matched controls, medical students had significantly higher rates of suicidal thinking in the past year, at almost twice the rate than at their age-matched controls. Looking further into our research, we've noticed that the most consistent related factors associated with these negative outcomes have been increasing years of study, going higher in medical school, increasing age, as well as being female. Now, with these unfortunate rates, it's most significant that only 15.7% of medical students seek any kind of treatment. And when we think about the barriers to this, the most prominent barriers include a fear of lack of confidentiality and identifying stigma as being a barrier of access. And we know that medical students who suffer from depression tend to harbor these kinds of thoughts of, I'm less intelligent, seeking help is risky, if I get help, I'm weak, the faculty may see me as vulnerable, my peers think less of me, and I'm less competitive getting residency spot. Now these rates continue into the workplace, and what we see here is a graph looking at rates of burnout amongst the different specialties in medicine. And in the orange, we have data collected from 2011, and in 2014, we have data from, in blue, we have data from 2014. Now, with all the attention in the media, you might think that the rates of burnout might decrease over time. However, in fact, we see on average, it's increased by over 10% in rates of burnout across the different specialties. So what now? What can we do as a society and as physicians and trainees to address this constant force of mental health outcomes here? So in a systematic review, which is a study that groups together a whole number of studies to provide us with larger data, there were 28 studies that looked at interventions to address burnout in medical students. And what the interventions that were present was one, pass-failing grading systems. So in the past, many schools had either letter grade systems or percentile systems. And the introduction of pass-failing grade systems has shown to have a consistent impact on decreasing anxiety and depression, and shown to have a lasting impact of over a few years. The thinking behind this is that by taking away the pressures associated with the letter grade system, it's increased cohesion and collegiality amongst medical students. The introduction of mental health programs and counseling services into medical schools is also shown to have a consistent impact on decreasing depression and suicidal thoughts, most chiefly by increasing access. Finally, mind-body programs, including things like mindfulness-based stress reduction programs, has also shown to have a prominent impact on decreasing stress by equipping individuals with a better sense of coping skills to help address this. At the same time, some of the interventions that had less evidence were mentorship programs and curricular restructuring. So when we think about this as a whole, what I want us to consider is that there's really two ways we can start to intervene in terms of addressing burnout in medicine, at the organizational level, then at the individual or physician level. So physician-directed or individual-directed includes providing individuals with mindfulness-based stress reduction programs or educational programs or exercise. And at the organizational level, it involves addressing larger scale issues, including scheduling, decreasing workload, and integrating a larger program, perhaps of mindfulness and other things, into the existing framework at the school or program. And what we see is that the weight tends to lie more heavily with the organization. That we tend to be much more impactful if we dedicate our resources to addressing the organization. Now, as someone who's been a researcher looking at interventions into burnout for medical students and physicians, in particular, I was involved with research looking at mindfulness in medical students, both in a face-to-face study. And what we saw there was, while the intervention was actually helpful for the individuals that were able to attend and enroll in our study, there were many individuals that couldn't participate due to the fact that there was scheduling issues and time constraints. And what we tried to do, second to this, was to do an online study involving equipping medical students with online resources and a whole online program. But at that same point, we arrived at this barrier of that the workplace culture had so much of a barrier to preventing students from accessing these resources that it didn't help to the same extent we were hoping for. So in conclusion, tonight we've talked about a number of things. We've talked about the causes. We've talked about the facts of what underscore burnout and mental health outcomes in physicians and medical trainees. We've talked about the impact for the physicians themselves, patients, society at large. And we've talked a bit about the strategies involved in addressing burnout in physicians. And we've also begun to share with you some of the stories, the people here tonight. And to conclude, to draw our attention back to our gentleman, Adam. As you recall, Adam was a physician. He worked in the United States, involved with residency training, suffering from depression, as well as alcoholism. And I'd like to conclude with what Adam acquired in his process of recovery. Number one, it's the essential to have a self-care plan. And that in this process, we need to, as individuals, also come to terms of what are the skills, the yoga, the meditation, the counseling, the therapy, that can be helpful in equipping us with the resilience we need to move forward. Two, stereotyping. That, as Adam points out, we often tend to harbor quite negative beliefs about those who suffer from mental health outcomes in those around us. And in fact, what we really know is that individuals like Adam are sometimes the face of these conditions. Stigma is another important factor in terms of the workplace itself and how its attitudes are towards individuals suffering from burnout and mental health outcomes in medicine. That at times there's a tremendous amount of barriers that are in place to prevent these patients from getting back to work. But oftentimes what we can see is that the physicians that are able to access the care and treatment that they need are those that can be the most compassionate and the best healers in our midst. 4, vulnerability. And that alludes to the fact that we need to be able to be vulnerable, to understand the challenges that are in our midst, and to get the help that we need to move forward. 5, professionalism and patient safety. We can take away from this that it's most important that we get the help, and that with that help, we can address these problems. And 6, developing a support network. No man is an island, and we can't come into this by ourselves. So to conclude with Adam's own words, when a colleague dies from suicide, we become angry. We mourn, we search for understanding and try to process the death. And then we go on doing the things the same way we always have, somehow expecting results. One definition of insanity: it's way past time for a change. Thank you very much.